Hi, my name is Emma Killing. It is December 16th, 2021, and I will be doing my Unit 4 case study presentation. The first case that I selected to review is case number 3, where we have a 47-year-old male presenting to the ER with severe pain in the right greater toe and is non-weight bearing secondary to the pain. There was no apparent trauma to the toe, and the diagnosis suspected is gout. So we'll be reviewing some of the blood samples and the urinalysis performed and determining what is the best explanation for the presentation of gout with this patient. The first option is the overproduction of purines, and this is not the correct option because the degradation of purines generates uric acid, and this increase in the production of purines would be reflected in the urinary uric acid levels, which we don't see in this patient. The second option is the decreased salvage of purines, and this can explain the increase in uric acid generation, but not the plasma urate levels and the lower than average urinary uric acid output. The disorders associated with a decrease in the salvage of purines, such as Lesch-Nyhan syndrome, have accompanying cognitive and behavioral dysfunction, which once again we don't see in this patient presenting in this case. And adenine phosphoribosyltransferase deficiency has a normal serum uric acid level, which doesn't fit with the labs of the patient in this case once again. So the third option, and what I believe is the correct answer, is a decreased urinary excretion of uric acid. So the urate levels are high in the plasma, and this set of symptoms corresponds with an individual which has a high BMI, type 2 diabetes, or a diet high in purines. We don't have this additional detail in this case study, but we can kind of presume from the number of liters of pop that the patient consumes daily that there is some sort of dietary issues going on with the patient. So this high plasma urate levels are considered precipitating factors for gout, and then this is the best explanation for the symptoms that the patient is presenting with. The next question about the switch from diet pop to regular and the number of liters that the patient consumes daily. There is a potential impact on the dietary modification on this presentation of gout for the patient. That results may be exacerbated by the sudden influx in sugar consumption, and some research has shown that the high intake of fructose-rich industrialized foods can influence uricemia. And then my sources for this case study will be listed in the the transcripts. The next case study that I selected was case number 4, where we have a presenting 58-year-old female with progressive fatigue and weakness over the course of the last 6 months, including diarrhea and some peripheral numbness and tingling, as well as loss of balance while walking. She is tachycardic to 110 beats per minute, but her other vitals are within normal limits. Also presenting with pale conjunctivus and beefy red tongue with the loss of papillae. Cardio results include a rapid but regular rhythm with a grade 2 out of 6 systolic murmur at the left systolic sternal border. And neuro results include decreased sensation to the light touch and vibration in lower extremities, and the patient also has low hematocrit levels. So the diagnosis suspected for this patient is megaloblastic anemia, and I will be explaining which of the following vitamin deficiencies is the probable cause for this presentation. The first is iron deficiency, and while the clinical presentation of iron deficiency includes weakness and fatigue, but it is often accompanied by sallow skin, pale pallor, rapid heart rate, brittle nails and hair, etc. And an iron deficiency may account for some of the patient's symptoms, but is not the main cause of the presentation. The next vitamin that I will be discussing is B6, and once again, some of the symptoms of a B6 deficiency overlap with the presenting symptoms of the patient, but some of the main defining symptoms of a B6 deficiency include seizures, weakened immune system, peripheral neuropathy, mood changes, dermatitis, scaly lips, and glossitis that we don't see in the patient. So the answer that I believe is correct is a vitamin B12 deficiency, which is the most likely cause, and the clinical symptoms align with the presentation of the patient, most notably the fatigue, shortness of breath, peripheral neuropathy, mild diarrhea, and the beefy red tongue with loss of papillae. These all correspond with the B12 deficiency in the patient, as well as possibly a mild iron deficiency. And then this vitamin impairs purine metabolism, and the process by which this happens is that B12 is required for remethylation of homocysteine to methionine by methionine synthase. It is also required for the conversion of methylmalonyl-CoA to succinyl-CoA, and deficiencies in B12 can increase the levels of methylmalonyl-CoA, and cobalamin inactivation decreases purine and methionine synthesis. So lastly, some additional testing that may assist in the differential diagnosis include an antibody test, where we check for antibodies to the intrinsic factor, and a methylmalonic acid test, where we determine whether the individual has a B12 deficiency if their levels of methylmalonic acid are elevated. Once again, my sources will be listed in the transcript. Thank you for your time.